Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Hello, welcome back. Okay, again, this is Dr. Ian De Vera, and for the second part of my lecture in your Pediatrics Clinical Skills Genesis, okay, we will be discussing all about Frichmond, okay, and I will insert along the way some tips to monitor the pediatric patient, because as we all know, okay, the pediatric patient is not a small adult. There are a lot of things very different. Although there are things that are similar, there are many things that are very different in children, okay. So we will be talking about these two, more on the Frichmond, okay, and a little bit on tips and tricks on how you will monitor the patients when you rotate in your pedia wards, okay, pedia ER, okay, basically when you rotate in your pediatrics rotation, okay. So what is Frichmond? Ano ba yung Frichmond na yan? I'm sure somewhere along the way narinig nyo na yan, lalo na kung dumaan kayo during clerkship, okay? Malamang naituro na rin sa inyo, pero we will discuss it again, we will review it, okay? Para maalala nyo. Kasi kung minsan pag 1 month ka lang rotate sa pedia or once or twice mo lang siya ginawa, minsan makakalimutan mo. So ano nga bang Frichmond? It is an endorsement tool used by different pediatric training institutions. Okay, I've asked my friends, I did my research kung saan nga ba talaga nag-originate yung Frichmond, kung meron bang journal or literature to it, and pare-parehas kami walang mahanap. So I'm not sure pero I'm thinking na mukhang dito sa mga training institution to pinauso at utilize para mas systematic yung pag-report, yung pag-endorse ng mga pasyente. And I find it very useful, not just in pedia, actually we can use this in other subspecialties, pero dito sa Pilipinas, if you're rotating in the big institutions, the top, the big four, the level 4 accredited pediatric training programs, so PCMC, PGH, UE, St. Luke's, UE, UST, okay, mga level 4 training institutions, you will encounter this method of endorsement, okay? It's important to note that there's a basic format, but there are institution-based differences. So, huwag kayong magugulat kung may ituturo ako dito, tapos parang, Dok, bakit sa hospital kung saan ako nag-rotate parang iba? Kasi pwedeng mangyari yun. But the general format, okay, the general idea is very similar. Siguro mga 90% similar yan, mga 10% differences lang yan, okay? So, the Frichmond method of endorsement, so Frichmond is a mnemonic, Frichmond, okay? And what does it stand for? F is for your fluids, okay? Some institutions will add feeding, okay, in your F, so fluids. R is for respiratory, I is for infectious, C is for cardiac, H is for hematologic, M is for metabolic, O is for output. In PCMC, it is for output. In PGH, it is oncologic. Okay, so I came from PGH, med school in PGH, internship and clerkship, PCMC during my residency. So for most parts, I will be talking about what we did or what we do in PGH and PCMC. So yan, output sa PCMC, sa PGH, oncologic yan. N is for neurologic, sa PGH, MOND, and D, magkasama, neurodevelopmental. Sa PCMC, magkahiwalay, neurologic, and D is for diet. Okay, in other institutions, yung D nila, digestive. Okay, so daanan natin isa-isa yung bawat components ng Frichmond para pag nag-endorse kayo, makita nyo kung ano yung mga kailangan yung ilagay doon. And I will also be showing snippets, screenshots of Frichmond format that we used to use in PGH when I was a clerk back then. So, matagal na nun guys. Pero nagtanong ako dito sa mga residente sa PGH, very similar pa rin naman din yung ginagamit. Okay? So for fluids, take note of the type of the fluid being used. So you usually use there, for example, D5LR, plain LR, and then we used to put the rate. Okay, so depends on your institution. Some institutions will put the specific rate. In PCMC, what we use is kung ano ba yung strategy. For example, is it maintenance? Is it mild hydration? Is it moderate hydration? Or pwedeng 50% of maintenance? So pwedeng ganon or pwedeng specific rate. If it's hydrating, you put the duration. For example, mild times 8 hours. And then you will put there reassess after 8 hours. Specific time. For example, 2 p.m. reassess and adjust the fluid. Okay, so again, basically the Frichmond is an endorsement sheet. Okay, para pag nag-rounds kayo, pag tinignan mo, alam mo agad, itong patient na to, 2 p.m. kailangan ko palang i-check yung fluid niya. Okay, please take note that pediatric patients are prone to congestion. That's why it's very important to measure and give your fluids accurately. Okay? And also be careful in your potassium-containing fluids. Example, lactated ringers, IMB, and M. Okay? If you have a patient with renal problem or patients with hyperkalemia, make sure na tama yung binibigay yung fluids. Baka may potassium niya sobrang taas tapos nag-hydrate ka using LR which contains potassium. So you have to take note of these. Okay? So this is an example as you can see. So yan. Dito sa example na to, since galing sa PGH, they included the feeding in the Frichmond. So you can, pwede, depende sa institution mo. Usually pag feeding yan, nilalagay pa nila yan. So ilang cc every ilang hours. So 45 cc Q, 3 hours. So EBM is express breast milk. Okay? If NPO, tinitingnan kung gano'ng katagal siya naka-NPO. And then yan, fluids, fluid intake, HGT, nilagay na nila dyan. The HGT you can also put in the metabolic part. So again, as you can see, there's no hard and fast rule. It depends on your institution. Okay? And yan, pag merong hypoglycemia, nakasulat na rin dyan. The output is already placed there also in the fluids part. Sa PGH, that's how they do it. Again, in PCMC, yung output namin nandun siya sa O, output part. Okay? Respiratory, what do you put in your respiratory part of your Frichmond? O2 support, if there is. So, naka-cannula ba yan? Naka-face mask ba yan? Naka-intubate ba yan? Kung naka-intubate siya, you put your mechanical ventilator settings. You also put the ET tube size and placement. Para pag nag-rounds yung residente, ET size 7, level 14. Tapos pag check niya, wait, nasa level 10 na lang to. Baka nahugot pala. Okay? ABG results. If there are ABG requested, what time was it done? And more importantly, what is the interpretation? Nakasulat yan dyan. And also kung kailan yung next na ABG. Okay? Medications, okay? Meron bang nebulization? Okay, salbutamol, budesonide, so yan. And if you're weaning, dyan din nilalagay instructions. For example, decrease FiO2 by 10% every 2 hours. So yan, dyan nakasulat yan. So this is an example of your respiratory components. So yan, intubated, ET size blank, level blank, neck vent settings, FiO2, RR, PEP, PIP, IT, okay? You can also put the mode there, kung pressure AC ba siya, CPAP, SIMB, and then your ABG values and interpretation, plus orders for weaning and other orders kung mag-repeat ka ng blood gas. Okay? When you're monitoring the respiratory condition of your patients, you have to know the normal respiratory rate. Okay, so there are a lot of normal values in pediatrics. This one is from your PALS, your pediatric acute life advanced life support training. Okay, so yan, neonate is up to 16. That's the upper limit. From beyond the neonatal period, which is 3 months before 1, it's up to 50. 1 to 5 is 40. 5 to 10 is 30. More than 10 is 20. That's the upper limit of RR. Beyond that, the patient is 50. So medyo madaling tandaan. Neonate 60. 3 months hanggang 1, 50. 1 to 5, 40. Tama? 5 to 10, 30. More than 10, 20. So it's 60, 50, 40, 30, 20. Neonates 3 to 12, 1 to 5, 5 to 10, more than 10. 60, 50, 40, 30, 20. Okay. But But also be careful of bradypnea. So you have patients intubated or in respiratory distress, naka-face mask kayo, tapos takipnik siya, nasa 60 yung RR niya, tapos biglang mamaya 10 na lang yung RR. So doon okay lang, hindi siya takipnik. Bradypnic na yun guys, nagre-respiratory failure yun na yun. So basically napagod na siya, kaya hindi siya humihinga ng maayos. So very dangerous, you have to watch out for that. Okay? Remember the signs of your respiratory distress. Okay? You have your alar flaring. We all know that. Subcostal, intercostal retractions. Okay? Kapag yung retractions nyo nasa supraclavicular area na siya. Oh, grunting. Okay? And gasping. Those are already signs of impending respiratory failure. So, patients who are having these signs, malamang malapit na ma-intubate yan kasi malapit na silang mag-respiratory failure. Impending respiratory failure. Okay? And also, again, be careful of silent takipnea. So you have patients na takipnik, pero wala ibang signs and symptoms, you have to watch out for these patients. Okay? So these are the areas for retraction. Again, sabi ko sa inyo, in children, lalo na malnourished children, very small neonates, mga preterm neonates, you may be able to see subcostal and a little bit of intercostal retractions, very shallow, that can be normal. Lalo na kung sobrang payat sila. Pwedeng normal breathing na, hindi sila takipnik, parang lumulubog. Okay lang yun, hindi sila takipnik, hindi sila in distress. Okay? But if you see those findings, tapos the patient is takipnik, tapos naghahabol ng hininga, maalon yung tiyan pag humihinga, then those are signs of distress. And again, if you have suprasternal, supraclavicular, and the use of your neck muscles in breathing, then those are signs of impending respiratory failure. So be careful with those patients. Okay? So here's an example, a picture of a patient with subcostal retraction. Okay? In your respiratory monitoring, in your respiratory part of your Frichmond, you also have to monitor your oxygen support. Sinabi na natin kanina yan. Okay? Please take note of these important facts. If you're using nasal cannula, okay, please make sure that the maximum flow that you are giving is 4 liters per minute only. Okay? Beyond 4 liters per minute, you should be shifting the patient to face mask already. Okay? So wala ka ng benefit beyond 4 liters per minute. Yung oxygen, FiO2 na na-deliver mo, halos parehas na yun. Plus, sobrang sakit na nun. Okay? So guys, have you ever tried using nasal cannula? Try nyo minsan. Okay? Gamit kayo ng cannula, tapos try nyo yung i-adjust yung oxygen flow niyan. Of course, make sure na malinis yung gamitin nyo. Okay? Sobrang sakit niyan. Yung 2-3 LPM, medyo hindi na siya ganun ka-comfortable. So I see some residents, some interns, minsan naka 6-8 LPM tapos nasal cannula. Please do not do that. Okay? For face mask, it's important to remember that you cannot go lower than 5 LPM. Okay? Going lower than 5 LPM, you will have carbon dioxide retention. Okay, you may have carbon dioxide retention. So, technically speaking, guys, 1, 2, 3, 4, that's nasal cannula. 5 pataas, that's face mask. Okay? So, pag nag-wing kayo, do not forget to shift to nasal cannula. Di ba? Pagdating ng 5, baba mo ng 4, balik kayo sa nasal cannula. So, technically, walang 4.5. Di ba? Makakita ka ng 4.5 LPM. Hindi, di ba? Pagdating ng 4, 5 na yung next dyan. Okay? If you are doing your bag mask ventilation, okay, you're doing your cardiopulmonary resuscitation, please do not forget to put your reserva bag in your bag mask valve. Okay? Kailangan may reserva bag yan. And you do it at 10 LPM. Nakakita ko minsan nagbabag sila, ayaw tumaas ng utos ng pasyente. Pag check mo, ito nangyari, ay hindi pa na-connect ng residente dun sa auto supply. Hindi pa na naka 10 LPM. Wala pa lang reserva bag. Very important yung reserva bag. Okay? If you're using your bag at 10 LPM without the reserva, you're technically giving around 40% FiO2 lang yan. Ang baba niyan. Okay? Whereas if you have your reserva bag, you're able to give up to 90% to 100% FiO2. So please put your reserva bag. Make sure that your O2 is running at least 10 liters per minute. And as clerks and intern, pag may code, pag may resuscitation na nangyari, those can be your role. You can check those small things dahil kung minsan nakakalimutan siya. Okay? So sinabi ko na yung mga blood gas and ventilatory settings. Okay? Let's now move to infectious. So anong kinakabit or anong nilalagay natin sa infectious ng Frichmond, yung I? In your infectious, you put there your antibiotics. Okay? Very important is kung ilang days na siya. Okay? The culture and sensitivity results, and usually you put there the fever pattern information, like this one. Okay? So we put the antibiotics there, and the dosage usually expressed in milligram per kilogram per day, or milligram per kilogram per dose. Guys, wag nalilito. Okay? Again, institution-based ito. So, kung minsan, nilalagay nila MKD. Yung iba, pag capital D, ang assumption is day. Pag small d, ang assumption is dose. Huwag niyong pagpapalitin yun. Ano ibig sabihin? For example, ampicillin is usually given at 100 mg per kilogram per day. In 24 hours, 100 mg per kilogram. Okay? Divided in 4 doses kasi Q6 siya. So 100 divided by 4, that is equivalent to 25 mg per kilogram per dose. Okay? I guess nyo? 100 mg per kilogram per day Q6 or 25 mg per kilogram per dose Q6. Yun yung ampicillin. Okay? The day, kung gaano katagal na ba siyang naka-ampicillin. Lagi kong tinuturo sa mga residents to. Okay? You count the actual doses given and not the day. Okay? Kasi, well, depende kung saan kayo nagpa-practice. Kung minsan, there are patients who cannot afford to buy their antibiotics na puputol. And that's not ideal. Pero when you count, again, you count the doses. So, for example, ampicillin is Q6. So, after 4 doses, that is considered 1 day. Tama? Okay? So, what if your patient is already given 6 doses? 6 doses na ngayon. 6 doses, okay? So, pag naka 6 doses na yung pasyente, paano mo i-report yun? I-report mo yun as ampicillin day, pag apat isa, day 1 plus 2. Okay? So, ampicillin day 1 plus 2. So, ganun yun. Ampicillin day 1 plus 1, day 1 plus 2, day 1 plus 3, day 2. Okay? So, that's how you count. So, depende sa doses, depende kung ano yung frequency ng antibiotics na binibigay. Okay? You put in your infectious, your latest gram stain and culture results and studies, and if they are pending, for example, awaiting urine culture, awaiting tracheal aspirate culture. And then you also put there your Tmax, the fever, maximum temperature, and the fever pattern. For example, last day of fever. In cases where the duration is very important, for example, dengue, kung saan minomonitor natin yung days na may fever siya, nilalagay din namin dyan yan. Day 5 of fever, for example, day 1 afebrile. Yun. So, day 5 of illness, day 1 afebrile. Or day 5 of illness, day 0 afebrile. Ibig sabihin, nag-fever pa siya. So, those are the things that you can put there in your infectious. Okay? The next is your cardiac, letter C. And what do we put here? We put inotropes if your patients are on inotropic support. Cardiac medications, for example, the patient has congestive heart failure. So you put there furosemide, for example, captopril, okay? If the patient is on digoxin, okay? And you put your 2D echo findings. You put when it was done, kailan ba yung last day, and the cardiac diagnosis is present. So katulad yan, okay? So usually your inotropes, we put the dosage there in microgram per kilogram per minute, okay? So yan, so 5 microgram per kilogram per minute, okay? 10 microgram per kilogram per minute, okay? Tapos kung ilang days na. Okay? Hypertensive medications is usually put in this column as well. Okay? And special endorsement, for example, you're titrating your dopamine, your dobutamine, so ilalagay yan. Titrate by 2.5 microgram per kilogram per minute every 30 minutes or every 1 hour. Yan. So pwede nyo ilagay sa cardiac. Okay? When monitoring your patient's cardiac status, it is very important to know these following. So you have to know the normal values for heart rate, your blood pressure, okay? You have to palpate your pulses. Okay? So guys, again, heart rate, blood pressure is very important kasi when your blood pressure falls below the normal for age, that is considered hypotensive shock already. But please remember, there's what we call your compensated shock, wherein your systolic blood pressure is maintained, okay, but your body is already compensating for whatever pathologic process is going on na papunta na siya doon, papunta na siya sa hypotensive shock. So what are the signs of your compensation, your compensated shock? Your pulses, okay, from strong peripheral pulses because of vasoconstriction, okay, pwedeng humihina yung pulses na yan, okay, your capillary refill time, okay, of 2 to 3 seconds, kapag nagva-vasoconstrict na yung extremities mo, again, sabi nga ni Dr. Denver, nung nakinig kayo ng ating buwasan session, di ba? Okay, the priority of your cardiac output, of your circulation are the vital organs. So kapag nagsha-shock yung patient, kapag hindi na niya ma-maintain yung cardiac output niya, okay, the blood flow is directed towards the vital organs, so the peripheries, the extremities, sila yung less priority. Okay, so systemic vascular resistance will increase, the blood flow decreases. Ano nangyayari? Lumalamig, bumabagal yung refill time, humihina yung pulses. Okay, so those are very important. So when you check the cardiac status, it's not just the heart rate, it's not just the blood pressure. Okay, the blood pressure is the last to go. Pag bumagsak yung blood pressure, marami nang ibang nangyari bago bumagsak yun. Okay, so you have to touch your patient, feel the extremities, is it cold? Touch and check for the capillary refill, feel the pulses. Okay, oxygen saturation also, it can be a sign of cardiac compromise. Okay, so there are a lot of values again to memorize. Sa bata may sleeping pa, may awake pa. Okay, do you have to memorize this? Yes, of course, you're in training, you have to know these values. Okay, so ako, usually, eyeball method ako. So, shortcut ko. Ano yung shortcut ko? In newborns, upper limit is 160. So, usually, yun yung tinitignan ko. So, pag more than 160, 180 yan, okay, mataas na yan. Okay? Yung 2 to 10 years old, dali lang yan eh. So, usually yan, nasa mga 120s yan. Okay? Tapos, ito, yung 3 months to 2 years old, kung titignan nyo, layo rin kasi ng range guys, 100 to 190. Okay? Basically, ang shortcut na ginagawa ko dyan, basta pag more than 10 years old, dapat hindi yan lumampas ng 100. Okay? Kapag 2 to 10, nasa 120, okay? Pag lumalabas na ng 120 yan, chinecheck ko na yan, okay? Pag 3 to 2, 140 yung ginagamit kong parang middle value. Tapos sa neonates, 160 to 180, okay? So, huwag nyo kayo kukuha dyan, wala sa libro yan. That's just my personal preference, okay? Yan lang ginagamit ko when I do my rounds, when I do my assessment of the patient, okay? Of course, again, you do not interpret this alone or singly. You have to compare and interpret it as a whole. So, check also the pulses, okay? These are the areas for palpation of the pulses. We have central pulses, your carotid and your femoral and your peripheral pulses, such as your brachial, radial, and ulnar, okay? Guys, the pattern is usually from distal going to, okay, going to the center of the body. Okay? So what I do is I check yung distal pulses kasi malamang kung mahina yung distal pulses niyan, malamang yung kasi yung central pulses mo, yung near the center of the body mo, pwedeng malakas pa sila, pero yung distal nyo pwedeng humina na yan. Pwedeng sila yung maunang humina. Okay? So pag puro central yung pinapalpate nyo, puro carotid, puro brachial, you might be missing out na nawawala na pala or humihina na pala yung peripheral pulses nyo. Okay? So it's better if you can check all, okay? Pero ako, ang chine-check ko, usually dumidiretso na ako dun sa pinaka-distal. And ang assumption yan, pag malakas yan, malamang malakas din yung brachial, malakas din yung carotid. Okay? The same is true with the temperature of your extremities. For example, may patient kayong nagsha-shock. Pansinin nyo, pag malamig yung buong kamay niyan, when you do your hydration, when you do your volume resuscitation, if it's a volume problem, dahan-dahan yan magiging warm. Until such time, kunwari, bumalik na yung blood pressure niya, Doc, 90-60 na siya, yung heart rate niya, bumabagsak na, nag-i-improve, gumagana yung fluid resuscitation natin. Tapos pagpapa nyo, Doc, warm na yung palms niya, yung tip of the fingers na lang ang cold. So, ganun yung progression. Again, from the periphery, okay, siya yung unang papangit, pag improvement, siya rin yung last na mag-improve. Okay? Blood pressure estimates. How do we know if the blood pressure of the child is hypotensive or hypertensive? There's a very complicated chart with normal values, okay, wherein you have to check the height of the patient, tapos ipa-plot mo siya dun sa chart, okay? You have to know that. That's not part of our discussion right here, right now, okay? Medyo matagal siya ituro, okay? But what you have to know, for quick assessment, we have a formula to estimate the blood pressure limits, okay? We're talking here about systolic values. The lower systolic limit of your blood pressure, ibig sabihin, pag bumaba dito yung blood pressure mo, hypotensive ka na, okay? For patients up to 10 years old, the formula is age in years times 2 plus 70. So for example, 5 years old, 5 times 2, that's 10 plus 70. Ibig sabihin, 80 is the lower limit ng systolic. Ibig sabihin, for a 5-year-old, yung 80-50, normal pa yun. Okay? So, for example, 3 years old, 3 times 2, 6 plus 70, 76. Tapos ang nakuha nyo, 80-50, normal pa yun. Okay? Ano pag 80-60, normal pa ba yun? 80-60? Oh. When the difference of your systolic and diastolic blood pressure is 20 or less, that's what you call narrowed pulse pressure. Again, that's a sign of compensated shock. Pag nag-narrow na yung pulse pressure, compensation na yan, compensated shock na yan. Okay? So, in children 10 years old and above, the lower limit is 90, like in adults. So, pag 11, 12, 13, 90, 60 na yung pinakamababang pwede. Okay? For hypertension, similar formula, pero age times 2 plus 90. So again, this is just for eyeballing. This is just a shortcut method. So for example, 10 years old, 10 times 2, 20 plus 90, dapat hanggang mga 110 lang yung upper limit. So pag may 10-year-old ka na nag-120, 130 over 100, ganyan, hypertensive na yan. Okay? So other signs to look out for, cyanosis, okay? Mottling, also very dangerous. Pag may patient kayo na nagsha-shock, tapos nakikita nyo, nagmamattle yung skin niya, those are signs of circulatory compromise. Okay? Okay, so hematologic, okay? You put here your CBC values and your blood transfusions if present. Okay? So ayan. So I will not teach you anymore the fishbone method of CBC because nag-iiba-iba yan for different institutions. Magpaturo kayo sa residence nyo and orient yourselves, okay? Most of the time, hindi lang nagbabago yung hematocrit sa hemoglobin. Hemoglobin dito, hematocrit sa baba. All the other parts of the Frichmond, nag-iiba-iba yan, okay? Important to endorse dyan, blood transfusion. So meron ba siyang transfusion, gaano karami, ilang aliquots, to run for how many hours, and usually kung ilan yung interval. Okay? And you can also put there if you have repeat tests. For example, repeat CBC after 6 hours of the third aliquot of your PAC RBC. Something like that. Okay? Metabolic is again straightforward. These are your electrolytes, interventions, and instructions. So all the metabolic parameters that you have to check, if needed, dyan natin nilalagay sa metabolic. Okay? Oncologic sa PGH, yan yung nilalagay nila, the diagnosis, the stage, the biopsy. In PCMC, we put output. So ano nilalagay natin sa output? Okay? We usually put the intake, 24-hour intake, and then the 24-hour output. In an ideal world where you can monitor everything accurately, guys, dapat magbabalance yan. The intake should balance out the output, ideally. Okay? Pero syempre, hindi natin memorize lahat yan, measure lahat yan eh. Saka meron pa mga tinatawag na insensible losses which you cannot measure. Okay? But it's very important to see, lalo na for patients with renal problem, patients who are in intensive care units, patients who are having diarrhea or vomiting, you have to measure each of them accurately. And you will put there, for example, vomiting, gano'ng karami, ilang ml, ilang beses. Bowel movement, gano'ng karami, ilang ml, ilang beses. Okay? And then the urine output. Okay, you have to put the urine output, and usually it is expressed in cc per kilogram per hour. Later on, I will teach you how to compute that. And lastly, fluid balance. And fluid balance is simply input minus output. Okay. Yeah. So when do you refer? You refer usually if you have a decreased urine output. Okay. Especially for patients whom you are doing hydration. Okay. So itong mga patients ko may mga losses sila na dehydrate, kailangan mag-hydrate ng fluid. You have to check because if your urine output is decreased, that can be a sign of either may kidney compromise ka na, okay, nagkakaroon ka na ng kidney injury, or your hydration is not adequate. Okay. And what are the cutoff values? Again, there are ranges, but to easily remember things, these are cutoff values that you will see in books. Okay. For the urine output in older children, so adolescents o puntang adult, most books will say na 0.5 cc per kilogram per hour is the minimum. For younger children, so please correct this. Okay. This one is older. The next one is for younger children. Mas mataas yung ating minimum output. It should be around 1 cc per kilogram per hour. So if you have a small child that the UO is less than 1, you have to refer and assess. For bigger children, adolescents, adult, so 0.5. Pag less than 0.5, kunwari nakuha mo 0.4 lang, you have to refer. Okay? Fluid balance, this is just an example. Okay? It's not actually hard and fast na pag more than 1 liter, masama na yun. Again, it depends. For example, you have a patient na sobrang daming losses, nagtain ng 10 beses, tapos nag-hydrate ka, tapos pag check mo ng chart, yung fluid balance mo 1 liter, okay lang yun. Kasi hindi mo pa na-account yung mga losses niya outside the hospital. Okay? You understand? Pero for example, may patient ka wala namang losses, nagkamali pala yung IV rate nung niran ng nurse, and then when you check, ang input niya is 2 liters, tapos ang ihi lang niya is 500 ml, meron kang 1.5 liter na fluid balance na naiwan sa katawan. And then, when you check the patient is congested. Clear breath sounds ng admission ngayon, may crackles na siya, puffy na yung eyelids niya. Then, that is something to be concerned. It's concerning kasi you have to assess, nag-fluid overdose ka, nag-congest ka ng patient mo. Okay? So, kanina ko pa binabanggit yung urine output expressed in ml or cc per kilogram per hour. How do you compute it? So, literal, it's ml divided by the weight, divided by kung ilang hours. So, example, you have a 10 kilogram child, tapos ang shift mo, 8-hour shift, 100 ml yung kanyang output. So, pag tinanong ka ng resident, adequate ba yan? Okay? So, you divide 100 divided by 10 divided by 8 hours. And the answer is 1.25 ml per kilogram per hour in 8 hours. Okay? Is it clear? So for this patient, the output is adequate. Okay? The patient is having 1.25, which is more than 1, okay, ml per kilogram per hour of urine output. Okay? Neurologic, okay, what do we put here? The neurologic diagnosis, a workup, such as CT scan, imaging if there's needed, special instructions, and please add there your medications. So for example, the patient has epilepsy maintained on phenobarbital, valproic acid, okay, and we also put the dose, okay. So in pedia, we usually always put the dose. For ampicillin, nasulat 100 mkd, phenobarbital, 5 mkd, okay, so nakalagay yun, okay, and other special instructions. So this is how it looks like. For patients with acute head trauma, you also put there the GCS score because it's very important to monitor if the patient is deteriorating, and also the pupils, the reactivity, and the size, okay. So, yeah, GCS scoring, deteriorating status, seizures, okay? Medication, sinabi na natin yan, okay? Be careful when giving your anti-epileptic medications. I don't expect na actual level kayo na yung pagbibigyan ng mga gamot ng mga residente nyo. But if they were to instruct you, for example, Doc, pakipush na itong phenobarbital, please take note that there are minimum, okay, rates of infusion. Because if you give it too fast, you can have detrimental adverse effects. Pwede ka magkaroon ng CNS depression, cardiac arrest, okay? So, for example, phenobarbital is given at a rate of 1 mg per kilogram per minute. The dose of phenobarbital is 20 mg per kilogram, okay? So, ibig sabihin, you have to give that dose, 20 mg per kilogram, over 20 minutes. So, dahan-dahan yun. Sobrang bagal nun. So, kung may infusion pump kayo, better, you do your infusion pump. Otherwise, kung mano-mano kayo, sobrang dahan-dahan yung ipupush yun. Okay? So, these are some emergency medications for seizure that's nice to know for your level for interns and clerks. So, diazepam, the dose is 0.3 mg per kilogram IV. If it's per rectum, it's 0.5 mg per kilogram. And please remember the maximum dose, 5 to 10 mg per dose. Okay? So, yeah. So, another thing that you have to remember is your GCS scoring. So, I'm sure you're very familiar on how to do it in adults. In children, is it the same? Well, for the eyes, halos parehas lang yan. For the motor, halos parehas lang. Usually, yung verbal response yung nagkakaiba. So, this is a beautiful table from Nelson. So, yan. Ang bata, okay, na i-score mo ng GCS scoring verbal output. So, ang 5 is appropriate words, smiles, fixes, follows. So, nakikipag-interact yung bata sa'yo. So, okay siya. Whereas, when your patient is irritable, consolable, okay, crying siya, pero consolable siya, tumatahan siya, that's 4. Pag persistently irritable lang siya, lalo na, again, ang GCS scoring, guys, for very small children, it's not as strict or as straightforward. Medyo may subjective component yan. So, for example, yung irritable, you compare it to the baseline. Mami, ganyan po ba yung baseline? Natural yan pag bata tinusok mo, malamang irritable yan. Pag yung bata, meron pang stranger anxiety, malamang pagharap mo irritable yan. So, you have to look. Mami, baseline ba nito? Dito, mabait na bata to. Okay, ito na bata ngayon lang, sobrang hindi ko siya makatahan. So, maybe that's a GCS of 3. Okay? Restlessness and agitation, that's 2. Okay? Of course, pag walang response, that's 1. Okay? Motor, how do we do? Obey's command. Yes, pag kaya na niya mag-follow, kung age appropriate na siya. Pero most of the time, we just do descriptions dun sa motor response, okay? So usually we say, for this patient, the patient localizes to pain. Okay? And what's more important? What's more important is the progression, okay? Nag-rounds ka ng umaga, GCS mo 13, nag-rounds ka ng gabi, GCS mo 13 pa rin, okay lang yun. Pero nag-rounds ka ng umaga, 13 siya, pag-rounds mo ng gabi, biglang naging 8, oh, that's deteriorating, okay? That's dangerous, okay? The same is true with your motor response. Nag-rounds ka ng umaga, your patient localizes to pain. Pag-rounds mo sa gabi, nagde-decorticate na lang siya. So, it's the progression, that's very important, okay? So, yan. And lastly, for D, it's your diet, okay? Other drugs, okay? In other institutions, digestive. So, again, in PGH, these components are already included in their F, fluids and feeding. So, sa PCMC, diet ang ginagamit namin. So, NPO, if there are any orders, hydration, methods use, progression, and other drugs on board. Nasabi ko na yan. And lastly, you can also put there other important endorsements. Monitoring, Q4 ba, Q1 ba, what do you watch out for, and other things to do. Facilitate CT scan, follow up blood culture, and sometimes mga endorsement sheet, nandun din yung mga pangalan ng mga residente in charge. Okay? So, I hope you're able to learn something, and I hope you're able to learn a lot, okay, with regards to your Frichmond strategy of endorsement and monitoring. Okay? And again, please remember that this is very much institution dependent. So, the Frichmond of one hospital might not be exactly the same as the Frichmond of another hospital, but the thought flow, the process, the general framework and structure will be very much similar. Okay? So, thank you for listening. Okay? Again, this is Dr. Rivera. So, hope to see you soon again.